Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways.
And it shows the importance of competency, right?
Yeah.
So we've all sat through an airway lecture like a lot of people are listening to now, but you have to follow it up with the hands-on skills, I think, is probably the key point. And that's what our organization, especially, Dr. Hill is really great in leading that charge and bringing these trainings around to our ambulances and saying, okay, we've already done the PowerPoints, we've already talked about this procedure, or you've listened to this podcast. Now I'm going to put the Roush Quick Drake in your hands, and I'm going to give you the scalpel, and then you need to do it. So it's kind of where the rubber meets the road is where I like that part, because not everyone is that type of a learner either. You can listen. I'm like, I'm not getting it. And then you're going to have a hands-on learner that's going to be like, no, I need to do this. So we need a high level of competency with hands-on skills to perform this in that oh shit moment so that you are going to perform and be successful and not do damage.
I'll tell you, I learned a hard lesson not that long ago. I was doing a lecture with Katie Uropoli with AirMed, and I was telling her, the most senior guy, the most experienced guy should be the guy doing your intubations. And she said, not in my mind. She goes, in my mind, it should be the most junior guy, because someday those people have to replace us. And if you keep relying on the one guy that does it all the time, you're going to screw yourself. And I really changed my mindset where it was like, she's exactly right.
Absolutely.
There's a time and a place, though.
There is a time and a place. Don't get me wrong.
Yeah.
If there's something that I've seen before that maybe it's not registering or this is different, maybe I would be the best choice for that, and maybe without. But, I mean,
you want to set them up for success.
If I'm brand new and I've never done the procedure,
it's not the time.
And this guy's a physiologically difficult airway, I probably
and that goes back to
learning
past
on him.
lectures. I mean, doing the 3-3-2 rule, doing a Malman-Patty score. There's reasons and ways that we should be determining the difficulty of this airway. Not to say that this is going to be that. I mean, this should be pretty. I mean, the neck mobility is huge, but.
I wanted to say something earlier when you were talking about it being a option of last resort, right? The way that is often interpreted is I have to do all of the things to get here, but I guess it also needs to be said you can make big jumps if you have to in your techniques if the situation is proving to you, right? So the patient that has their face blown off and I see some bubbles and I stick a tube, tube in the bubbles and I don't get chest rise and fall, I don't need to do 4 other things. So you can move quickly.
Yes.
So the speed in which you get to accessing the neck doesn't necessarily have to be this crawl, walk, run over 5 minutes. Your patient where you could ventilate them.
I had a whole emergency department. We called anesthesia down. We had tools I'd never seen before, trying to get an airway from up above.
Correct.
That we could still ventilate. We were still able to ventilate him through. But
you were able to take your time because you were able to ventilate somewhat, and you worked to the peak of that, right? But
we may not always have that luxury.
I agree.
We may not, and that patient probably wouldn't make it to him if we didn't, right? If we didn't have the ability to be like, I took one lick with the laryngoscope and it's just an absolute disaster. Things are upside down and hanging off, and
correct.
But I think that
all the teeth are on one side of the mouth, right? And then okay, cool, I can move quickly.
That's important though, that you put a blade into the orifice. Right. We won't even call it a mouth at that point.
A GSW or something. Yeah, right.
I put it in there. I saw bubbles. I didn't see bubbles. I couldn't make. You made an attempt.
Yep.
Great.
Correct. Yeah, and I'm not saying you have to do all those things, and I know.
I don't want it to
be intended or taken that way, but I guess you will make the transition faster, obviously, and it depends on your level of cert. So if I show up and I'm on a basic EMT and I'm going to start trying to bag them and that doesn't work and then the medic shows up, I'm not going to place a King Airway or an iGel. I might try intubation first, to your point, to see can this be successful. But I know if everything's upside down, I can't see the proper structures, or if their anatomy is significantly damaged, then I know I need to transition to that. It's not. You do not have to perform each one of those steps, right? It's not a cook. It's not a cake recipe.
I was just going to say that's the beauty of our protocol is that it's not an ABC protocol. It's
I just think it's
anticipated loss or this or that, or the words in there actually mean something if you read it, where it's like, I can go backwards and forwards and lateral here if I need to. So
I guess my point was more so of like proving to say like, I'm not trying to put a MacGyver out there and be like, you know what, I can't ventilate him or I can't intubate him. I'm just going to crike him, or I'm going to jump to that step. It's like, no, that patient needs to be, you're not able to ventilate them. You're not able to oxygenate them. And,
I just want to make sure that I mean, I fully understood where you were coming from.
But somebody else might not.
I wanted to make sure that, it was understood that, that can scale quickly or slowly. I mean, we had two different examples here, of one where we would scale quickly to neck access rather than, very progressively to neck access, right?
I think it also needs to be said that for traumas, if you've got trauma to the neck and you can see the airway from outside, it's okay just to throw an ET tube into that airway.
Correct.
I have an airway.
Happened
in my shop.
That's a great point. And to your point, a lot of patients out of nursing homes may be stoma or trach patients already.
We're going to talk about that in the next episode. Yeah.
And so these won't be patients that we're intubating orally anyways.
No, you're not going to go top down. Yep.
Sure.
So. All right, so then we'll transition on to some sort of cricothyrotomy kit like we kind of came in with. The Roosh Quick Trach is by far the most prolific in this area, so that's what we have here. I've got a few others here behind me, but ultimately it's all gonna kind of boil down to, you have to know your device. You have to practice with your device. You need to have a training device and periodic upkeep on this. It's a
it's just a big IV needle.
It's just a big it's an airway IV catheter, right? Is the thing that most people would associate with, and over the needle catheters are that's our bread and butter, right? We're we're vascular access experts. That's what we do, but there's a few things with this that need to be pointed out that actually, I don't want to say hinder, but make the insertion completely different than the mind model you have of putting an IV catheter in somebody. So the first thing is, of course, that this is curved a little bit, right? And of course, that's just curved to help with the natural anatomy and putting it into the airway. So I mean, the curve's not that big a deal. You can see the trocar here. It's it's curved as well, and those fit together like that. But what is harder to see, and if we're looking at it from over top here, is this is far narrower here at the distal end, and it's far fatter here at the proximal end. So when you put this between the thyroid cartilage and the cricoid cartilage, and let's use this trainer here because this is far smaller, still a little big, but it's a little more representative of what we're dealing with here, is when you put this in between here with, of course, leading with that catheter. I'm just showing you the plastic catheter, that you are actually wedging that thyroid and cricoid cartilage apart as you're trying to pass this down. So the mind model of I get the pop when I enter the vein, and then I kick that needle off, and it threads.
Doesn't happen.
It's not like that. So
you're going to be met with some more resistance.
A lot more resistance. And, as a matter of fact, I know of 2 cases where quick trachs early in their deployment were used, and both times the staff aborted because they felt like they were hurting the patient because they were pushing really hard, right? Now, of course, saying that now is kind of tongue-in-cheek. It's like, well, if you stop pushing, they die, right? Yep. But again, I can see you got this new tool. You don't want to do harm, right? And we really hadn't talked that through. We really didn't understand when those were first rolled out that was going to be a thing. And I didn't appreciate that until I did my cadaver experience with these, and I put that in. I'm like, just waiting for it to thread off and just whoop right down in there. I'm like, and I really had to thread that down in there. And that's expected behavior, right?
Correct.
Now, it was a little stiffer in a cadaver than it would be in a live human because I didn't have some, localized bleeding to juice it up a little bit. But nevertheless, if you're in a situation where you have to pull the trigger on this, you're going to meet some resistance. Their neck is going to flex back. They're going to sink down into the cot mattress or onto the push down onto the floor. You're going to have to put some shoulder into it. Right now, you're not going to just jam it in. Right, it's escalation of force until you get it appropriately through the cricothyroid membrane. But I want everybody to understand that that's just not this. It's not the experience of an IV catheter going into a vein and just sliding right off. And
now, we can talk about this, but you can modify your use of this by two ways. If it's a bigger person and you need more space and you want to have less resistance, you can make a vertical incision through the skin, and understand that the reason for that is the skin's the toughest, one of the toughest organs. Toughest thing to get through is the skin. Once you're subcutaneous on this, the underlying tissues are not as difficult or rough to get through as the skin. So you do a vertical incision with a knife, or you can actually use the very tip of this to cause an incision to get through the skin, and then advance this through.
Absolutely. Use that.
Use the cutting edge to bevel
trocar.
Yeah, almost as a knife, as a blade. Absolutely.
And so when we're doing cracks too, but all of our techniques using all of the skills we have, we're making skin incisions to get through the skin. Once we're through the skin, no matter what I'm doing, advancing dilators or whatever, I never have to cut anything else. The skin's the issue to get through.
Absolutely.
Just remember, like we said before, that you're going to bleed a lot.
Yep, and you are going to bleed a lot.
And that's okay. You just have to work past that. And believe it or not, blood makes a decent lube.
It does. This is going to bleed less than a surgical cric, unless you're going to be making that incision in the skin. Because just like when you're placing your IVs, you're going into a place that has a lot of blood and even pressure behind it. It still doesn't bleed out, short of DIC or some coagulopathy you're worrying about. But understand that you have plastic up against walls. The plastic's going to put pressure against it, and you're not going to have bleeding, if any.
We spoke to this a little bit earlier. This has a 4.0 endotracheal tube inner diameter equivalent here, right?
Yep.
So, and I know I'm not doing these side by side or sequentially, but we can, just with that catheter on the end, I can get far more. I hope you can appreciate that I can squeeze far more volume, and more importantly, we can get that same volume out, right? So we can
get live.
So we can start actually providing some minimal amount of ventilation, and of course that's air in and out.
But then
as my definition
compared
of
to that,
compared to this,
squeeze it with two hands.
Correct, right. And remember, when this is popping open, that's not air coming back this way. That's air coming in from there. So that might be misleading if we're looking at the overhead camera, right?